welcome to another quick tips from the lab. However, this time we are at UAB Dental School in Birmingham, Alabama with Dr. Celin Arce from Costa Rica, and he is full-time faculty here at UAB. And today we're going to hopefully teach our audience more about how to do fixed hybrids using zirconia as the bridge material. Something like this, however, this is a PMMA, something that Celin will talk about during this video. But these type of cases, full arch, fully edentulous, multiple implants, they're becoming more and more popular. Last year alone, we did over 150 arches of zirconia prosthesis in this manner, and that doesn't include the titanium bar cases that we did. So we're featuring a case that we did with UAB in the grad pros department with Dr. Arce. And without further ado, I'd like him to go through the treatment plan, the protocols that we both need from our clinicians in the lab standpoint in order to have a successful end result. So thank you for being here with us.
Thank you for having me. Well, we were discussing earlier about the importance in the diagnostic phase, especially planning the Inter-Occlusal space, because that's going to determine if we're going to plan for a titanium framework over acrylic teeth,
okay,
or zirconia, full arch zirconia.
Okay, let me ask you a question. How much inter-occlusal clearance do you need for one versus the other?
Okay, so depending on the literature that you read, for titanium frameworks with acrylic teeth on top, you're going to need between 13 to 16 millimeters of restorative space. For full arch zirconia, those ones we can go a little bit less, maybe between 11 and 12 millimeters for the space.
Okay, that sounds about like what we have in the lab.
So, of course, the importance of, in the diagnostic phase, to trim implant to achieve that restorative space. That's going to make the life way easier to get the restorative space that we need.
Okay.
In this case, you can see in the surgical aspect, once we place the implants, we get that restorative space. If we don't have it, to make an alveoplasty of the ridge.
Yeah.
That way we can level the bone and achieve the necessary space that we need. And also, very important is to create that very even ridge, and that's gonna allow us, when we design the final prosthesis, to have a very even intact surface, because if we have a ridge that is like a roller coaster, that's gonna create, when we design the final restoration in a different levels, and for the patient that's a little bit more difficult to clean underneath.
That's right. We see that a lot. We see doctors doing the case on ridges that needed to have the bone reduction, and then you end up with a very concave intaglio of the bridge. So that's great.
That creates a problem. So that's I would say the first step that is very important. Once implants are placed, of course, then the final impression and the creation of the master cast, that's I would say the most critical. The way that I like to take the final impressions is to take the diagnostic impression of the implants with the closed tray impression pose, and I make a preliminary cast with the implant analogs. So this is now my master cast. On top of this, we place the impression pose, and I do my verification jig in the lab, and I already have it sectioned. So when I come to the mouth, to the patient, what I do is just take those open tray impression pose and join them in the mouth with the either global resin, or the one that I like the most is the Primo pattern that is like here. So once I join the impression pose in the mouth, then the technique that I like the most, of course, is the open tray, and a very accurate impression. Of course, that's going to allow us to have an exact master cast. Of course, we need to verify that master cast is accurate and the same 100% accurate as the patient. The way that we do is with the same verification jig.
So you try the jig in again after you've luted it the initial time?
Yes. So once I join them in the mouth, then once I have my master cast, then I verify that there is no discrepancies between my master cast and my verification jig.
That's an extra step that Dr. Arce is doing to make sure that it fits. Since you're at grad pros and you do a lot of the model work yourself, the lab, when we're dealing with GPs, we make the section jig on the initial cast, and we send it to them numbered in section, and then we require them to lute it intraorally, and then they pick that up in a custom tray, and we use that for the master cast.
Okay. Yeah, that's another way to do it.
But let me interject and say this: out of in the past 3 years, say around 300 or 400 arches, we've had a few break, and the ones that have broken have been when the doctors said, no, I'm not going to do the jig appointment, everything's good, or maybe they poured their own model and said, no, this cast is verified. So we go with it, and then it always snaps when they're torquing it down.
Okay. That means that it's not a passive restoration.
That's right. So big disclaimer there, you've got to do the jig appointment procedure.
The other important aspect is if you're working with your implants at a fixture level, or we'll be working with the implants at abutment level. For this particular case, we have multi-unit abutments. That means that we're working at abutment level. So it's way easier to achieve that passive fit, since we're no longer working at the platform level of the implants. If you're working directly to the platform of the implants, it's doable, but then it's very, very important for that case to verify that you have an accurate cast. And in those cases, you need to for sure take x-rays to verify the complete seat of the impression post.
That's another thing that we've seen happen. We've seen doctors say that everything was verified and accurate, and then we ask for an x-ray image, and you can see a gap. Yep. I think that is a key, is to x-ray your impression copings when they're seated. Otherwise, if one has a gap, then the restoration is going to rock and it'll break.
Okay, so once we have an accurate master cast for this particular patient, we started to have the wax setup, and that wax setup is going to be the one that we're going to utilize to design either the PMMA restoration or the final restoration. So I took my MMR records with my wax ring, set my vertical, then set the teeth, did the try-in to verify the occlusion, the lip support, the aesthetics of the wax try-in. Once the patient's happy with that, I'm happy with that, then we send it to you guys, and that wax up is being digitized, scanned in the lab, and from that setup, we're going to design the PMMA restoration. That's the one that we have here. So obviously it's a POC, polymethyl methacrylate, and after that it's basically layered with pink composite for the gingival areas. So after that, either the patient can wear this for a few weeks, or we can just utilize this to do the try-ins, verify the occlusion, aesthetics, lip support, etc., etc. If we're happy with that, then that's when we go and move forward to the final restoration for the zirconia. For this particular patient, since the patient was very class 2, skeletal class 2, you can see in the design framework that we had everything in the posterior monolithic zirconia, and we just facial cutback in the anteriors. In patients that I've seen that they're very class 3 or they have a very edge-to-edge relationship, it's very important that we design the framework with the zirconia aspect all the way to incisal edge and just the cutback at the facial, and that's going to help us to minimize the porcelain chipping over time.
Talking about the final, what kind of steps were needed by you to seat the final bridge?
So basically, once I get the final restoration back, obviously I was very pleased with the aesthetic result and the anatomy and the pink porcelain of the final restoration. So since the restoration is already cemented to the titanium cylinders, basically I just have to see the prosthesis and verify. Since I'm working at abutment level, just verify. In this case, I can just do it with the Explorer, since I can have visual of the interface with the abutments. Just verify once I screw all the implants that I don't have any rocking. I do the 1 screw test, just 1 screw in the front, 2 in the back, no rocking, and
Okay.
then one screw by each one of the implants,
Mhm.
and verify that there is no rocking, and we achieve the passive fit of the restoration. After that is a matter of just verifying the occlusion and seal the screw axis with pink composite.
On this particular case, Dr. Arce did a select hybrid. So you saw that the case was cut back in the zirconia. We have a master ceramist who's layering those. They're layering the pink with multiple colors. I think it's a very beautiful bridge restoration. Well, thank you so much. Thank you for having us here.
Thank you for coming.
Appreciate it. It's
Okay.
very good to have you. If you have any more questions, just email the lab, and we'd love to do some of these type cases with you all. Thank you.